Well, hello and welcome to this session of the Center for Podiatric Education. In this session, we want to continue in our review of some topics relevant to management of the geriatric patient. And in this session, we thought we'd talk about skin changes that occur in the aging foot. Looking at the older patient that we take care of in many of our practices, some of the general changes that we see that are responsible for much of the pathology that we must evaluate and treat include a general reduction in the amount of collagen in the skin and subcutaneous tissues. The skin oftentimes is much thinner, and we have not only easier injury because of the thinner skin, but loss of the normal barrier function. There is loss of water retention, a loss of sebum and sweat function, and therefore the skin gets much drier and predisposed to infections and injuries because of that dry skin. This is particularly accentuated in the patient who has diabetes. We do want to remember that many patients with diabetes have autonomic neuropathy. They lose innervation to the sweat glands. This is a manifestation of small fiber neuropathy and oftentimes can be a first manifestation of neuropathy preceding even sensory or motor functional deficits. The skin becomes less elastic, and we do have decreased function and numbers of Langerhans cells, as a result of which we have some degree of immune incompetence in the skin and increased propensity to pick up infections, including fungal, bacterial, and viral infections. Anyone in general practice knows that there are some common skin disorders that are encountered in the geriatric patient. Certainly onychomycosis and various dystrophic nail deformities are encountered on a regular basis, and it's important in disease prevention really to make an appropriate diagnosis of these patients, treat the patients either topically or systemically. Tinea pedis and skin cirrhosis commonly present in the geriatric patient, and here again, these can be predisposing factors to rather significant pathology, infections, ulceration, and even limb loss. And here again, it's important to identify tinea pedis and skin cirrhosis. A common misdiagnosis is to look at patients with keratotic dry skin and not realize that not infrequently this is actually a manifestation of tinea pedis, and to actively treat these patients. We know that skin keratoses of various types, focal and diffuse, can result in discomfort, pain, and ulceration. We also know that atrophy of the normal fat pad is not at all uncommon and can be associated with a variety of pathologic conditions, and here again, supplementation of that fat pad is oftentimes important not only for patient comfort but in the prevention of skin breakdown and ulceration. We know that in the older patients we also see an increased incidence of various skin neoplasms, some more commonly seen in the elderly patient, some rather unique to the elderly patient, and of course ulceration, which is a common topic of discussion in our profession. We have both intrinsic and extrinsic factors that affect aging in the feet. The aging process, of course, occurs in all people. It starts really in our 20s. Most of it is pre-programmed degeneration of cells, and this is a genetic and etiology. although various people age at different rates and not everyone ages at the same rate or in the same way, and the skin type and genetics probably are the major determinants. If we look at what we are actually dealing with in aging skin in the foot and lower extremity, obviously skin mitosis is reduced, and because we have reduction in skin mitosis, the skin is thinner, again predisposing it to injury and loss of barrier function. We have reduced sebum production as we get older, so the skin becomes more dry, oftentimes pruritic, and here again, skincare recommendations, the use of appropriate skincare products is oftentimes helpful. If these diagnoses are made, then appropriate treatments should be initiated. The decreased fat in the hypodermis as well as subcutaneous tissues lead to increased cold sensitivity and oftentimes pain because of pressure over bony prominences. Increased collagen cross-linking, particularly with associated advanced glycosylation end products in the diabetic patient, results in lack of thickness of the skin and lack of skin mobility, and we have stiffness and clumping of collagen and elastin, here again resulting in decreased mobility. As with most organs over time, we have reduced telomere length. For those of you that don't recall, these telomeres are repeating fixed sequence of bases such as adenine, guanine, cytosine, thymine at the end of chromosomes that are retired for chromosome stability. Over the years, with repeated cell division, the telomeres become shortened. Eventually, they lose their ability to provide chromosome stability, and this results in a loss of the cell ability to reproduce. The telomeres are fixed structures of repeating bases at the end of the chromosome, and again, with time, repeated reproduction leads to the inability of the DNA to replicate. We also have, over time, some loss of telomerase activity, which is necessary in order to maintain the telomere. Again, these are fixed basal units, and we find that most telomerase activity is primarily maintained in the basal cell layer of the epidermis, but is not found in the dermis and other areas. With aging, we see intracellular changes. We see changes in the nuclei of the cells found in the skin. We find changes in the mitochondria. We see decreased endoplasmic reticulum and distorted Golgi apparatus, so that we have reduced ability not only to produce DNA or maintain DNA, but also to produce proteins and to store necessary proteins and components of nucleic acids. Collagen cross-linking increases with aging. It also is affected by certain disorders such as diabetes. These cross-links are non-reducible. They increase over time, and cross-linking also increases with exposure to free radicals. And as a result, the skin loses its pliability, its elasticity, it loses its structural competence, and becomes more liable to injury. And this process is accelerated in the presence of hyperglycemia. We also, with aging, have the effects of free radicals. If you recall, free radicals are substances such as oxygen, which have an unpaired electron. The source of free radicals are many, but as we age and we have the increasing effects of free radicals, we have breakdowns of DNA. with DNA mutation, inability to reproduce, and eventual cellular death. And certainly free radical damage occurs to many components of collagen, elastin, glycosaminoglycans, and lipids in the skin. Free radicals are generated in many ways, including exposure to ultraviolet light during inflammatory processes as a result of certain leukocyte functions, smoking, and again, these result in DNA damage as well as damage to skin components. We also see alterations in matrix metalloproteases. We often speak about MMPs in terms of ulcer management, ulcer prevention. We have the production as we get older of various collagenases, gelatinases, and other active agents that break down fibronectin and laminin and type 4 collagen. We have the production of elastase, which breaks down elastin. So with aging, we have many ongoing processes that affect the skin. Looking at this in a more histologic manner, a more gross manner, the keratinocytes show slower turnover and reproduction. The keratin that's present sloughs more slowly, so that we are aware that many of our elderly patients have a thickening of the keratin layer, oftentimes requiring some type of superficial or professional debridement or the use of agents such as keratolytics. The melanocytes present in the skin decrease in number and produce less melanin, and we have a flattening of the epidermal-dermal junction, resulting in an increased propensity to develop blisters in the aging patient. In the dermis, we see decreasing numbers of fibroblasts, and those fibroblasts which are present demonstrate decreased collagen production, as a result of which, again, the skin is abnormal, and this has many direct clinical effects. The most commonly discussed in our profession, probably the effects of wound healing, and one of the reasons that some wound care products are based on fibroblast deficit repair. We see decreased quantity and abnormal structure of collagen, which is weaker, again leading to more easily injured skin. We see less elasticity in the skin because there's less production of elastin. We see decreased quantity and decreased quality of the extracellular matrix tissues. And of course, everyone knows that we have at times with aging increased arterial disease, increased venous disease, and with aging, thinner, dilated, and weakened vascular structures. The subcutaneous tissue changes that we see in the foot include loss of the normal fat pad and thinning of the fat pad that's present. We see weakening of the normal skin retaining ligaments with loss or decreased vascular supply, decreased numbers of sweat glands, and decreased sweat gland function, again accentuated in patients who have autonomic neuropathy, such as those with diabetes. We see fewer sebaceous glands and less sebum production and fewer hair follicles. Again, all of this predisposes the skin to injury. So with aging skin, we have thinner skin, we have dry skin, we have reduced sweat activity, we have thinning of the dermis, as well as the epidermis and flattening of that epidermal junction. We have decreased blood supply and changes with loss of the hypodermal and subcutaneous fatty tissues. All of this telling us that in assessment of the geriatric patient, we want to identify the extent of the presence of these factors and initiate therapy to try to prevent injury to the skin of the geriatric foot as a result of these age-related changes. So if we look at skin as we go through our 20s and 30s and 40s and 50s, we see significant changes in the hypodermis as well as the epidermis and the dermis. We see free radical attack to the components of the skin, as was mentioned earlier. We start to see skin that lacks elasticity, increased collagen cross-linking, and reduced numbers of collagen fibers, reduced vascular supply, and changes that result again in a predisposition to the many skin problems such as infection, ulceration, blistering, fungal infections that we see in our older patients. A variety of extrinsic factors also are operative in defining the rapidity and extent with which we see these skin changes. Certainly smoking is a factor that we can speak to the patient about. Various forms of malnutrition can certainly affect skin health. Various hormonal disorders, particularly diabetes, thyroid disorders, ovarian disorders, all play a role in affecting skin in an adverse manner. Chronic disease states, again, can certainly play a role in advancing aging skin. And while it's not as big a problem in the foot as elsewhere, we certainly have the effects of photoaging and the effects of ultraviolet light and radiation on the skin. In the older patients, we have lack of estrogen. You want to remember that estrogen stimulates fibroblasts to reproduce. They stimulate fibroblasts to make collagen. And in our postmenopausal patients, decreased estrogen levels result in decreased skin health by resulting in a decreased amount of collagen. Smoking, of course, we counsel our patients that smoking will affect the blood flow to the skin as it does elsewhere. Smoking has significant effects on decreasing oxygenation to the skin, and increasing inflammation to the skin, generating more free radical byproducts, which again are operative in breaking down collagen and DNA. And overall, smokers have poor quality collagen and elastin, poor quality and decreased amounts of skin matrix components, less sebaceous gland and gland function within the skin. So that as one factor that we attempt to control in our patients with skin pathology, we certainly want to talk to them about discontinuing smoking, the reasons why they want to discontinue smoking, and document that discussion. With aging, we also have glycosylation of skin proteins as we do other proteins. These are non-enzymatic processes by which glucose literally attaches to the end of the skin proteins. It alters the properties of those proteins. It also initiates a immune response by the body against those same proteins. These are irreversible, and as you would imagine, this is a problem that's accentuated in the patient who has diabetes. Photo damage, not so much a problem in the foot as it is elsewhere, but we know that we generate free radicals. We affect DNA with ultraviolet light B and ultraviolet light A. This can result not only in accelerated skin aging with collagen cross-linking and abnormalities in DNA, but abnormalities in telomere function, and stop the DNA from replicating, but also can lead to certain forms of skin cancer on the foot as it can elsewhere. With aging skin, we have increased rigidity, lack of elasticity. There's an increase in the actin filaments within the skin. And again, this lack of elasticity is very much operative in the generation of many of the pathologic conditions that we see in the aging foot. So, summarizing these factors, we have intrinsic factors as well as extrinsic factors. We have the production of radical oxygen species and other radical species that lead to the breakdown of collagen, the reduction of production of collagen by fibroblasts. We have the inactivation of the inhibitors of matrix metalloproteases, as a result of which we have increased activity of these proteins. We have the activation of matrix degrading metalloproteases and increased synthesis of them. So in summary, we can look at differences in younger skin and older skin, and we could speak to the histologic changes and differences, and we could speak to the physiologic changes and differences. Now, in treating the geriatric patient, we want to identify these problems. We realize they are associated with increased risk of infection, injury, ulceration, and we want to actively treat these. And this should be part of our evaluation. The evaluation of the skin should be the first thing that we're looking at. And when these problems are present, we should identify them. We should diagnose them, and we should be actively treating them. Some of the interventions include actively treating tinea pedis and actively treating onychomycosis, not just having the patient come and have their toenails reduced or cut periodically, but letting the patient and family know that onychomycosis can be associated, particularly in patients with certain comorbid conditions, and patients who have vascular disease can be associated with significant pathology, and therefore we want to address that pathology with more than just trimming nails, whether it's going to be with topical therapy or systemic therapy. There are a variety of topical agents that can be utilized containing vitamin C, which is helpful for stimulating collagen synthesis, the alpha-hydroxy acids, various emollients and keratolytics as you feel are appropriate to utilize. We want to encourage the patients to avoid the use of heat and hot water in excess and decrease the use of harsh soaps, and rather use moisturizing body washes on their feet. Some of the problems that we see include heel fissures. Heel fissures should be addressed, should be actively treated. We understand that in certain patients, such as diabetic patients, patients with collagen vascular diseases, patients with poor circulation, that heel fissures can be associated with infection and can be associated with serious ulceration. Pruritus is not an uncommon skin disorder in the elderly patient. Now, in looking at pruritus, we always want to recall that this is a symptom, it is not a disease. And the question becomes, what is the source of the pruritus? It can be due to a contact allergy or irritant sensitivity, perhaps something the patient's applying to their foot or ankle. It can be a manifestation of a drug allergy. We want to remember that pruritus can be a manifestation of neuropathy. It can be a manifestation of tinea pedis, including tinea pedis incognito. So we may have patients that are reacting to the presence of the fungal infection, and yet clinically we don't see overt manifestations of the disease. Pruritus can be a manifestation of dry skin, skin xerosis, or astiotic eczema, winter itch, and here again, if that is the diagnosis, we certainly want to take appropriate steps to improve the quality of life of that patient and prevent injury. Pruritus can be a manifestation of diabetes or diabetic neuropathy. It can be a manifestation of any number of systemic disorders, including anemia, renal diseases, hepatic disease, thyroid disease. It can be associated with venous insufficiency, with excoriations and ulceration. And we want to remember that pruritus can also be a manifestation of an occult or known malignancy. In treating pruritus, we certainly want to see that The patient has controlled concurrent disorders. They may have an undiagnosed underlying disorder. The treatment ranges from avoidance of topical agents initiating the pruritus to treatment of their venous insufficiency, the use of emollients, at times antihistamines, topical steroids, or when necessary, systemic steroids for the treatment of the pruritus. Of course, in the elderly patient, any type of dermatitis is certainly possible, and here again it may be necessary to obtain an appropriate biopsy in an effort to identify the specific dermatitis present. Some of the more common forms of dermatitis that we see in our older patients included stasis dermatitis, astiotic eczema, and nummular eczema, or lichen simplex chronicus. And here again, we want to look at the general examination of that patient to make our diagnosis. We want to look at the morphologic characteristics of the particular dermatitis present, take a proper history, get the dermatitis in context with what we're looking at generally in that patient. Again, if there's significant difficulty in making such a diagnosis, then one can certainly consider appropriate biopsy technique. Usually a punch biopsy would be appropriate. Web space infections are not at all uncommon in the older patient. We want to remember our differential diagnosis. One would be, of course, erythrasma, infection caused by Corynebacterium minutissimum, and one may want to use a wood light or take appropriate cultures to make the diagnosis and then initiate appropriate antibiotic therapy. One can have interdigital tinea pedis or interdigital candida infection, erosio interdigitalis blastomycetica. And here again, proper identification of the infecting organism would be critical in order to initiate appropriate therapy for tinea, typically a dermatophyte, but not always, or the use of agents such as nystatin for the treatment of the candida infection when present. Not uncommonly, we have an initial fungal infection with a secondary bacterial infection, so-called dermatophytosis complex. Not uncommonly, we see gram-positive infection between the in the web spaces, or a mixed infection with Pseudomonas present due to the moisture that's present. Less commonly, interdigital eczematous eruptions and interdigital psoriasis can be seen. It is important to treat web space infections in the older patient because in the presence of vascular disease or immunosuppression, for example, the patient who is on biologics for the treatment of inflammatory bowel disease or a rheumatic disorder, for example, or the patient on chemotherapy for cancer, patients with neuropathy. In those patients, all of us have seen patients whose rather benign interdigital space infection has progressed to become a serious infection. And in my own career, I've seen a number of patients whose web space infections have progressed to become actual limb-threatening infection. And I've seen more than one patient lose a limb from what started out as a web space infection, but was uncontrolled in the presence of poorly managed diabetes, peripheral vascular disease, or immunosuppression. In the elderly patient, we see a variety of neoplasms. Really, there's very few neoplasms that aren't likely to be seen. And these include rather benign lesions such as stuccokeratoses or seborrheic keratoses, and again in the older patient, a higher propensity towards certain problems such as basal or squamous cell carcinoma, and of course melanoma. Stuccokeratoses and seborrheic keratoses are rather benign. They could be curetted off, they could be frozen off. They can be shave biopsied, however one wants to rid these lesions. You could laser them off, whatever technique you feel is appropriate in a given patient, and submit it for pathology. And certainly chronic ulceration or any suspicious looking lesions should be submitted for appropriate biopsy to rule out the possibility of a squamous cell carcinoma or melanoma. So in summary, we do see skin changes in the older foot and ankle. Basically, they are the result of diminished protein synthesis, decreased uptake of nutrients, DNA damage and inability to repair the DNA damage, the accumulation of advanced glycosylation products, and the accumulated effect of oxidative damage from reactive oxygen species, damaging proteins and lipids and other components of the skin, and we have reduced mitochondrial function. So we clearly have defined differences between younger and older skin. And in our job in prevention of amputation and improving quality of life, it is very important to identify these changes in the older patient and be proactive, talking to the family, talking to the patient, and providing appropriate care for infectious, non-infectious, eczematous changes and other changes in the skin of the elderly patient.